So I will be talking about a topic that I did not hear that was brought up by the panel, and that is using behavioral economics to incentivize people and patients to change their behavior. And rather than talking about a specific technology like blockchain, really explain to the audience and show the shortcomings of centralized health and speak to the importance of why we need to decentralize our data structure. Very briefly, in terms of background, I've been a pain specialist for 27 years. I've been involved in technology integration at least 15 to 17 years when the idea of the quantified self didn't exist. There was no cloud, there was no concept of the usage of data the way we think of it today. I've been intrigued and deeply dived into distributed ledger technology and cryptocurrencies since 2014. And I wear many hats, among them an advisor to the UN CFACT Commission on policy in blockchain. And I advise for the European Union and the African Union and work almost exclusively now in emerging markets, especially to things that pertain to GDPR and how to offer people through digital identity opportunities to develop not only health, but also wealth. So when we talk about digital health, we talk really about centralized data systems. And I like this definition from the WHO that not only talks as from a provider's perspective, the need to improve access and reduce costs and speak to access and equity, but also the idea that health is something bigger than just disease management and includes wellness and well-being and emphasizes the importance of social determinants of health. And we can see that we've been delving in the data ecosystem for at least 30, if not longer years, where we're combining both the digital and genomic revolution. And we live now, I would say, in a universe of endless data. I think the last count was over 170 exabytes of data that include not only things that we have passively curated from the different wearables and apps that have been spoken about this today, but also things that pertain to our interaction with the digital world, be it through our mobile phones and our computers. And when we boil down the interfaces of what generates this data, we confront basically three main categories of technology. So I think that talking about blockchain is incomplete without saying blockchain and I'll explain in a few slides what blockchain is, or what I think is an easy way to remember what distributed ledger technology is. But when we talk about telecommunications, Internet of Health things, and the whole universe of artificial intelligence and machine learning, obviously there are centralized and decentralized versions of them. And it's not the purpose of this conversation to talk about machine learning, deep learning, or federated learning. But again, I would like to urge the audience to think about what is the difference when things are centralized in a cloud or a honeypot or a certain area versus things that are distributed throughout all the users. Now, it is clear that digital health attracts huge investments. We see that even COVID didn't stop the increase in investments, and this year looks to be one that breaks the bank. After one quarter, we're already surpassing what has happened in previous years. And this feels like this is going to be a year not only with very large investments in later stage companies, but also in earlier multi-vertical sectors. I do, however, want to point out that despite the fact that the US market is less interested and up to a certain point compared to the European market, a bit in a blind spot, there is an opportunity for emerging markets actually to really succeed and leapfrog from their analog and paper-based solutions into this decentralized health. And to a large extent, I would say the lack of incumbents and the fact that the regulatory landscape is a little bit more straightforward really gives them an opportunity to not repeat the mistakes and the difficulties that we are confronting in healthcare, because it's quite clear that I would say the accrued cost of healthcare, the data silos and the data illiquidity, the friction that we sense, and the capital leakage that happens within the revenue cycle is something that is on everybody's mind and is not sustainable. Now, as mentioned in the previous panel, if anything, COVID showed that we need trust. When people ask me, so Alex, what did COVID do to you? They expect me to say, that I lived virtually and went less to restaurants. But actually what it did was that people came up to me and said, Alex, this thing that you've been involved these last 5-6 years, I really think we should start to pay attention. Could you explain what this is all about? And I would say that the best explanation, bearing in mind that the majority of us are not technophiles or have the necessary technological literacy, I would say that blockchain is the software solution to the social problem of mistrust. And we've seen that throughout the pandemic, following the recommendations of the CDC, looking at the numbers that are produced either by the federal government or by states, the manipulation of those numbers. There are thoughts that perhaps we have underreported the morbidity and mortality of COVID by half. The disorganization that is ongoing throughout our response to COVID, anywhere from not knowing the supply chain of toilet paper and hand sanitizers, all the way to coordinating the manufacturing and use of ventilators, and really posed a challenge to see what are the limitations of siloed data and the lack of interoperability. Now, for those who try to understand how does that happen, how does a replicated ledger really solve that problem, I like to give the example of me even preparing this presentation. So when I do it all by myself, I just write stuff. I put data in a ledger in an append-only database, and I'm only accountable for myself. But when I start to use Google Doc or Slides Doc, and I know that other people are looking at it, I start to pay attention, and I start to make sure that the data is more pristine, is more complete, that $19.95 is not $20, and that all the registrations that I put in are really truthful. And that at the end of an epoch, which could be an hour or a day, I can close that data and I can sign it off, and I can close it cryptographically and call that a block of data. And that block of data that I do on Monday, and then on Tuesday, and then on Thursday creates a chain, hence the word blockchain, which makes it not only tamper-proof and time-stamped and audited, but also immutable, transparent, and practically hackable free. And so this idea of where we create a world computer where we share this information shows different shapes and different forms of how we can solve the problems of today, for example, the pandemic. So in essence, blockchain is a peer-to-peer network technology that minimizes the need for trust agents. So I'm sure that the physicians among us are thinking already, this is wonderful, less administrators, less billers, less coders, but this is also in general in life, these trust agents that we don't need anymore. And the example that I give is we're all, some of us at least, are old enough to remember that we would call on the phone and say, operator, can I get this number? That's a trust agent. Or when I would call Australia, my mother would say, talk fast because it's very expensive. Now calling to Australia costs nothing. And that is thanks to VoIP, voice over internet protocol. And that doesn't require anymore the intermediary. And so DOIP would be data over internet protocol. And MOIP, for those who understand, are wondering what Bitcoin is money over internet protocol. So it's the ability for me to connect directly all over the world, 24/7, without the friction, knowing that what I'm doing is I am me, the person on the other side is the person that I want to interact with, and there can be a transfer of value. And not like the famous cartoon where you see a dog on the internet saying nobody on this side on the other side knows that I'm a dog. Now, blockchain comes in different flavors. There is a public blockchain, which is also called permissionless. And that is, if you wish, something like a world computer, where there can be hundreds of thousands or millions of computers that are all connected, and for that matter, all looking at this presentation and making sure that what I'm saying is accurate and correct and truthful. But then, of course, there are private blockchains. There are entities where we want to keep our IP, our secret sauce. There's some information that we don't want to divulge. And those are called private blockchains or permissioned, where the user has to be permitted by the blockchain authority before they can access and join. And that's similar to what we used to use as the intranet in the early days of the internet. And of course, there are hybrid solutions, what we call federated or consortia, which are already used by the industry. So for example, in developing the vaccine, it was important that different companies work together, and it was important for federal agencies and other governments to share data and information, that there will be a data flow and liquidity. And so there are areas that are permissionless without infringing on what is thought to be private. And the use cases, of course, can be in other highly sensitive areas, not just in healthcare, like banking, insurance, and government. Now, you might ask yourselves, why is this at all important? What's the difference between centralization and decentralization and distribution? And what you can see here is that when you centralize data, when everything is in a honeypot, there is one point of breakage. And that's when we hear these huge hacks. Yahoo, Facebook, Google. There's not a day that goes by that we don't hear about hospitals that have been subject to ransom. So when everything is kept to one point of failure, if Azure or AWS or Google Cloud just one day stops to work, then we really cannot continue our life. Whereas a decentralized network has less of those points of friction. And of course, when it's distributed, when each and every one of us are our own cloud, or can be part of other clouds. They're not only ways of protecting and making it attack resistant, but also other ways of doing business. And we've seen here that it's very difficult to collude once it's decentralized. So certain states that wanted to rig the numbers or change the numbers of the COVID patients that they had or the mortality that they had in order to look better for political reasons, that would be impossible to do in a decentralized system. Or censorship, where they would say, we don't want the public to know because we're scared that they will create panic. All kinds of reasons that show the weakness of using a centralized system, especially in a digital world that is facing a global threat. And the reason why this works is what's called the blockchain trilemma, which basically means you can have two, but not three, all three. So for example, if you want something that is decentralized and belongs to everyone, and you want it super secure, you just want it to be unhackable, like for example, Bitcoin or Ethereum, it can't be fast. It can't be fast because it takes time to go through all the nodes, all the computers. So that's why a transaction, which you do with Bitcoin, can take 10 minutes, which might be, for example, not good if I want to buy something, but can be perfectly okay if I'm doing a transaction of data on an electronic health record. And so the other types of blockchain that we see, the other products that are out there, use different flavors where you do less decentralization and you have better speed, or if you want to keep the decentralization and do faster, you open yourself up to less security. Now, the emerging use cases, which used to be, I would say, prior to the pandemic, a little bit more theoretical, are actually now strong and in use. One, of course, is the digital identity management, which is used for credentialing. The others, as you see here, are electronic health records and other type of financial and insurance records, decentralized clinical trials, and supply management, and I'll go over them quickly. So the first one, and to each one I just attached one example of many. I would say, most important of all is really the self-sovereign digital identity, or the identity that is owned by you. And basically this means that a centralized organization like the government, like the DMV, will determine, for example, your credential or your identity, and that will reside in your mobile cloud. And it can be stored in different types of clouds. It can be centralized or decentralized or a hybrid one. But the most important thing is that it can be pulled out at request very easily and instantaneously. And that all what you have to do is present a QR code that is already identified. And so, for example, I just came back from Switzerland. So there's really no need for me to every time fill out everything to the Swiss Airways. They already know my passport number. They already know my credentialing that was given either by the US government or the Swiss government. And it just saves time and energy and friction. The second use case is really supply chain. And so all the problems that I mentioned in the beginning, the ventilators, the vaccination, the toilet paper, the hand sanitizer, the inventory management can all be looked at using a blockchain through a QR code that is distributed through the manufacturer into the whole chain of distribution and to the users themselves. And this involves other technologies like IoT. We can look at the conditions that materials were transferred. We can scan the QR and see at every single point which truck brought what, at what temperature. And of course, this ensures privacy and authenticity, but also enforces the quality, because the price of failing at each point excludes that an individual or that link in the chain to not be included in future conditions. And so the reporting into dashboards can be given to different stakeholders that can query through that digital identity. When you combine this, and this is an example of where you can combine tracking people with tracking stuff or supplies, you get really a value chain. And this creates a complete ecosystem where each and every stage of it has different levels of anonymity, pseudonymity, security, ownership over the data, and makes sure that it becomes really a peer-to-peer transaction. An extension of that is decentralized clinical trials. And again, what's interesting is that it's patient-driven. And again, it is the individual through their mobile devices that are transferring their data directly by volition to the sponsored database. And then, of course, comes the patient-owned electronic health record. And you see here on the slide where it is the patient who can decide who sees what, who can edit, who can update. They can timestamp that. They can say that my doctor can see it from this time to that time. They can say that my insurance company cannot look at certain information. They can say that I want, for example, to talk to a sponsor and give them that information. It really puts the patient in a driving seat. So it's not a patient-centric, but a patient-driven ecosystem where there are permissioned and revocable accesses. And like I said, data is traceable, timestamped, it is portable. So it's not that it is built in a hospital and hospital A doesn't have what hospital B has, so there's no interoperability, but it's carried by the person itself. And most importantly, the person can carry monetary and non-monetary incentives. So a whole ecosystem of where the patient drives the interactions with the various stakeholders that right now is not the case, and where the patient is excluded from that economic activity. And that, of course, can go, and this is what we're doing in Africa, where we have also a wealth ecosystem that goes into the whole community with education, with manufacturing, with vendors, and with farming, where you can actually incentivize people to behave in a healthy way and provide them what we call tokens or rewards to have access to services, to healthy food, and to cheaper care. And finally, between professionals, and I'm coming towards the end of my presentation, where you can blockchainize the community itself and create an environment of trust where they can thrive, where you have verifiable credentials. These people can gain prestige within the community through their reputation, and they can get weighted voting according to their contribution to the network that actually bears the proposition value, and of course have a settlement layer where cryptocurrencies can be used as a token of their reward or opportunities for future investment. And so decentralized health is better because data is decentralized. We can trust it, not when I say because I believe Alex, but because it is because of its finality and computational trust. It is attack, censor, and collusion resistant. It can be part of a community that develops its own value proposition and consensus and engages in connectedness. And most importantly, something that was not spoken in the previous panel, where we include monetary and non-monetary rewards, where people actually, the citizens that use healthcare, are part of the economic activity. And so the future is to look at decentralized finance, look at their ecosystem, and see that they also have a sensitive, high trust private data environment where payments and exchanges and insurance and the ability to transact is very similar to that in healthcare. So I'll finish by saying two things. The first thing is that I hope I convinced you that data is like money. It belongs to you. It is private. You can use it whenever, wherever, and however you want. You can invest in it and accrue its value, and you can give it for charity. You can donate it. You can inherit it. You can own it, and you can lease it. And at the end, also, the real change will be that we will change now what people are, which are just simply health service consumers that are incentivized to use more and more tests for every pest, no more pills for every ills, and actually become not only health producers, which we're doing with value-based care, but also wealth producers through an inclusion in the economic activity. I think we arrived at time, and I want to thank again for the kind invitation.